Hi, I'm Cassie Calabrese, and I'm going to present a case that was seen in our multidisciplinary oncology clinic. This is an 80-year-old man with metastatic melanoma who presented to Rheumatology clinic with joint and muscle pain. Regarding his melanoma, he was diagnosed in 2020 with stage 1, was surgically removed. He received adjuvant nivolumab, a PD-1 inhibitor, for treatment of his cancer, and this was stopped for uncontrolled underlying diabetes and new onset joint pain. Unfortunately, several years later, he had recurrence of melanoma, metastatic this time, and was treated with adjuvant pembrolizumab, a PD-L1 inhibitor. With his first cancer treatment course in 2021, the evening after his first infusion of nivolumab, he developed diffuse and debilitating joint and muscle pain that was worse in his hips, shoulders, and knees and hands. He had joint swelling in his hands. He couldn't play golf and was very debilitated. He received 20 milligrams of prednisone with a slow taper and felt great, and his symptoms resolved, and they continued on with his cancer treatment. Move forward to 2023 treatment of his cancer recurrence. He received pembrolizumab, and after his third dose, he experienced recurrence of the very same symptoms: pain, aching in the shoulder, hip, and neck girdles, swelling in the hands and wrists, couldn't go up the stairs, couldn't play golf, elevated acute phases, negative rheumatoid factor, and CCP. He was referred to our Pharmacovigilance clinic, which is a multidisciplinary clinic in our Tossing Cancer Center for patients who develop complications from their checkpoint inhibitor therapy, such as these drugs. He had swollen wrists, tender joints, limited neck range of motion, very difficult getting out of the chair, elevated acute phase reactants. These are his hands. You can see they were very swollen, could hardly make a fist. He developed polymyalgia rheumatica as a complication from his cancer treatment, which we see occur about 5% of patients. This is a systematic review looking at 49 patients in the literature of checkpoint inhibitor-induced PMR. About 75% of these cases had enough data to apply ACR-EULAR PMR classification criteria, and 75% of those cases fulfilled criteria. Atypical features are these patients often had overlapping symptoms of inflammatory arthritis or needed higher doses of prednisone than you would treat a traditional de novo PMR case with. So he was started on 20 milligrams of prednisone for his PMR with complete resolution of symptoms. He does have diabetes, so he had elevated blood sugar and was started on the IL-6 inhibitor cerulumab as a steroid-sparing agent and was able to come off quickly, the prednisone. He continues to feel great, continues his cancer treatment with plans to complete 2 years of treatment with no progression of his cancer.